Dr. Karam attended medical school at the American University in Beirut. He is a board-certified, fellowship-trained gynecologic surgeon and clinical associate professor in the Stanford Medicine Department of Obstetrics and Gynecology, Division of Gynecology, Oncology. He specializes in gynecologic oncology, hospice and palliative care, hereditary gynecologic cancers, laparoscopic and robotic gynecologic surgery, and obstetrics and gynecology. He is currently the Director of Robotic Surgery and Outreach in the Division of Gynecologic Oncology. Ladies and gentlemen, please welcome Dr. Amir Karam.
Good. Thanks for, thank you so much for having me. And again, I want to thank the organizers from BACC for inviting me again to present some of our latest advances in ovarian cancer, both treatment and research.
Dr.
All right, if we
Karam
can move on
attended.
to my initial slides. Okay, very good. We jumped right in. So I just want to preface this slide. This is actually more updated. It's actually from 2022. The numbers may be a little misleading, but even though, as you can see, the number of deaths from ovarian cancer are still quite substantial, they still count as the fifth leading cause of cancer deaths in women. There's some bright spots on the horizon, both in the terms of cancer deaths and incidence. As you probably notice on the left side of the screen, where you look at the incidence, ovarian cancer is not all that common. It doesn't even factor in 10 most common cancer causes in the U.S., but it's still a leading cause of cancer deaths. So this is the good news that we have. This was published. This was the same data from a nationwide survey of patients with cancer and deaths from cancer. These statistics are up to 2021 or late 2021. And as you can see highlighted, there are some really bright spots in terms of ovarian cancer. Both the incidence and the death rate from ovarian cancer have been declining quite steadily from 2013 up to 2018, which is something that you don't hear a lot about in the news. And one of the bright spots in terms of cancer research and our efforts to fight this very deadly disease. So again, very, very good news in terms of the decreasing incidence, but more importantly, the decreasing death rate from ovarian cancer. As some of you may already know, there are different types of ovarian cancer. The most common type that we encounter is what we call the high-grade serous cancer. These are characterized by mutations in a p53 protein, as well as the infamous BRCA1 and BRCA2 genes. There are other subtypes that are more rare, like the low-grade serous, mucinous, clear cell, and endometrioid carcinomas of the surface. They have a different set of mutations, but are less common and in some cases less deadly than the high-grade serous cancer. This slide just goes over, the typical disease course for a lot of our patients with ovarian cancer. Unfortunately, most of our patients are still diagnosed at an advanced stage. Unfortunately, by the time patients are diagnosed, they're usually symptomatic. They usually have advanced stage disease, which typically will require surgery either upfront or after a course of chemotherapy to reduce the amount of cancer. This is frequently nowadays followed by maintenance therapy, and unfortunately, in many cases, patients progress and the cancer recurs. And in that situation, unfortunately, the disease is incurable. Despite efforts at additional surgery, more chemotherapy, unfortunately, in many cases, death ensues. The average or overall survival for our average patients with ovarian cancer is about 5 to 6 years. Although we have moved that needle up and in some cases cured more patients these days, as I will highlight later on in my talk. Okay, So surgery is the mainstay for our treatment for ovarian cancer, both in the early and advanced stage. And since most of our patients are um, diagnosed at a stage where the cancer is already spread beyond the ovary, the concept of surgical debulking is very important. And in this situation, for the surgery to be successful, you have to be able to remove all the cancer that you can see or feel, what we consider an optimal cytoreductive surgery. That often involves removing not only the uterus, the fallopian tubes, and the ovaries, but that fatty apron on the inside, which is called the omentum, which harbors a lot of the cancer spread that we see. We also see spread to lymph nodes as well as other internal or abdominal organs, such as the spleen and intestines, which sometimes requires removal of these organs, as well as this layer that covers the internal organs called the peritoneum. Regardless, the goal is still to remove as much of the cancer as possible. And we now know if we are aggressive surgically and leave less than 1 centimeter of residual disease, which is about 1/3 of an inch of residual disease, outcomes for patients are much, much better, particularly if we are able to remove all of the cancer that we could see or feel. This is a slide that illustrates the importance of removing as much of the cancer as possible. This is a study that was published more than 20 years ago, showing that as the percentage of tumors removed, and you'll see that on the x-axis, you'll see as you go from 10% of the tumor being removed to 100% of the tumor being removed, the median or the average survival goes up quite substantially. It's almost a direct link between the amount of cancer you remove and how long patients survive. Even in situations where you have stage 4 cancer, basically cancer that has spread beyond the abdominal cavity, the disease can still be cured. So it's not a hopeless situation even when you're faced with advanced stage disease. This is a patient who was diagnosed with stage 4 cancer. And even though the cancer had spread to an area of the chest, we were able to, in coordination with thoracic surgeon, remove all of the cancer that we could see or feel. This was followed by a course of chemotherapy with carboplatin and Taxol, followed by that maintenance therapy with this bevacizumab or Avastin treatment. And to this day, this patient is free of disease. So this is a patient that is now considered cured by many, all measures, and it started out with stage 4 cancer. Now, for many, many years, we've sort of struggled to find a successful treatment for ovarian cancer, particularly when it comes to chemotherapy. And the concept of delivering chemotherapy where most of the cancer is came up more than 30 years ago. This is because when the cancer recurs, even when the cancer comes back, most of the time it comes back in the same area where it showed up in the first place, the abdominal cavity. And this is where the concept of intraperitoneal chemotherapy comes in. So for over 30 years, researchers have looked at using or delivering high doses of chemotherapy inside the abdominal cavity to be able to beat back the cancer more successfully. This is one of our more successful trials using this approach. This is these are the results of what we call GOG 172, which is a trial using intravenous cisplatin, which is a chemotherapy that was used over 20 years ago, with Taxol, which is another commonly used chemotherapy, versus intravenous cisplatin as well as intraperitoneal cisplatin, followed by Taxol both intravenously and intraperitoneally. The results of this trial were at that point in time, back in 2006, considered sort of treatment changing, and so much so that the National Cancer Institute said that intraperitoneal chemotherapy should be considered the standard care for patients with ovarian cancer. The reason was that with intraperitoneal chemotherapy, you were able to extend the survival of patients with ovarian cancer by over a year. Unfortunately, this treatment is very difficult. and many patients cannot tolerate the treatment. This led to another number of adaptations over the years and another clinical trial looking at these alternative methods of delivering intraperitoneal chemotherapy because it was so hard. One of the reasons the treatment was so hard was because cisplatin is a very toxic drug. So we looked at substituting carboplatin, which is a more modern cousin of cisplatin that is now standard of care, to the cisplatin given intra-abdominally, and also using smaller doses of the drug since toxicity, particularly long-term toxicities, were an issue. Unfortunately, that trial was not successful. And this is one of the reasons this intraperitoneal chemotherapy has now lost a lot of its luster and is no longer being used very commonly around the US because any attempts to substitute or reduce the amount of chemotherapy has been unsuccessful, and since the treatment is so difficult on patients. Now, one of the reasons that the intraperitoneal chemotherapy was not widely adopted was because patients had to be retreated multiple times inside the abdomen. This was associated with a number of complications, including pain, the delivery device not working correctly, the toxicities accumulating over time. And this is where the concept of heated intraperitoneal chemotherapy comes in. With heated intraperitoneal chemotherapy, the chemotherapy is delivered just once inside the abdominal cavity at the time of surgery. In addition to the chemotherapy, which is circulated for about an hour and a half, and then sucked out entirely, we deliver also heated water. The heat itself is supposed to sensitize the cancer cells to the chemotherapy and make them more likely to be damaged and killed by the chemo. And this is just done once at the time of surgery. This ultimately led to a randomized controlled trial in the Netherlands, where the researchers then randomized patients to chemotherapy at the time of surgery or no chemotherapy at all at the time of surgery, followed by chemotherapy. So these are all patients who had advanced stage ovarian cancer. They all received what we call neoadjuvant chemotherapy, which is chemotherapy before surgery. When they were felt to be candidates for surgery, they were randomized. Basically, there was a flip of a coin to decide if these patients were to receive this heated intraperitoneal chemotherapy at the time of surgery or not. And then after they recovered from the surgery with or without the HIPEC, they then finished off the rest of their chemotherapy intravenously. In this situation, again, the group that received that heated intraperitoneal chemotherapy at the time of surgery did better. There was about a year of additional life that was afforded to these patients. Again, this is not a trial that has been replicated, but it has led a lot of us to consider using heated intraperitoneal chemotherapy in addition to surgery in those patients who start out by needing chemotherapy first. Now, as far as the regular treatment or chemotherapies for ovarian cancer, this is sort of a timeline of the various FDA approvals for different drugs to treat ovarian cancer. You'll notice that before 2014, all of the approvals were for traditional chemotherapies, from cisplatin back in 1978 to carboplatin in the late 80s, early 90s, and Taxol in the early 90s, all the way up to 2014. All of the approvals in terms of treatment for ovarian cancer were for regular chemotherapies. The most recent one was gemcitabine back in 2006 for patients with recurrent ovarian cancer. From 2014 on, all of the breakthroughs that came through for the treatment of ovarian cancer have not been for chemotherapies. They have been for much more targeted treatments, particularly this class of drug called PARP inhibitors. And this drug has really proved to be groundbreaking for the treatment of ovarian cancer patients. And this has led to the approval of at least 3 different drugs, 3 different PARP inhibitors in this setting. Olaparib, which was first approved in 2014, then rucaparib in 2016, and niraparib in 2017. Along with that, there was another drug that we commonly use in ovarian cancer called bevacizumab. It's an antibody. It's an infusion of an antibody that's designed to block the blood supply or block the development of blood vessels around cancer cells. And the reason PARP inhibitors are so important is we now know that chemotherapy works by causing DNA damage. And it does so by causing what we call double strand breaks in the DNA. Okay, so in a normal cell that has a normal mechanism to repair double strand breaks, the cell itself can recover. It can repair its own DNA and then survive this assault by the chemotherapy. However, in cancer cells, particularly cancer cells who are deficient in this, what we call homologous recombination pathway, so the pathway that allows it to repair this double strand break, the cancer cell cannot survive the double strand break that was caused by chemotherapy and then dies. This is particularly true in patients who have BRCA mutations. The BRCA gene is at the heart of this homologous recombination pathway, and a deficiency in that gene causes the pathway or the repair pathway not to work correctly, making cancer cells especially sensitive to chemotherapy. Now, it turns out that mutations in this homologous recombination pathway are actually quite prevalent in ovarian cancer. We think about 50% of our patients with ovarian cancer harbor some sort of mutation in the DNA of the cancer cell that leads to this what homologous recombination deficiency, making them very sensitive to chemotherapy. This includes, as I mentioned before, the BRCA mutations. These are commonly known as mutations that are transmitted in families, so what we call germline mutations, but they can also arise in the cancer on its own, what we call somatic mutations, without it being inherited from a parent. There are other mutations along that same pathway because it's a complicated pathway with a number of different proteins involved that could lead to the same effects. So half of our patients have a deficiency in this pathway. Why is this important? This is very important when it comes to the PARP enzyme. So the PARP enzyme also helps repair DNA damage, but what we call single strand breaks, what we call base excision repair. So what does this have to do with double strand break repair or the homologous recombination pathway? It turns out that if you cannot repair these single strand breaks and they accumulate over time, the DNA itself then breaks, and the absence or this single strand break that does not get repaired can then turn into a double strand break and cause the death of the cancer cell. Another mechanism is what we call PARP trapping, where the PARP inhibitor causes the PARP enzyme to glom onto the DNA and cause directly DNA damage and cause directly cell death. I want to introduce the concept of maintenance therapy because it is very important, particularly for all these drugs that we mentioned were approved recently for ovarian cancer. So as you can see, this is a typical course for an ovarian cancer patient. From the moment they're diagnosed until they are diagnosed with a first recurrence, which is typical for many patients with advanced stage disease, there's about a year and a half, about 6 months of therapy, and in the average patients, about a year after they finish their initial treatment with chemotherapy and surgery, we expect a recurrence in most of these patients. Unfortunately, despite more aggressive chemotherapy, the cancer keeps coming back faster. The next time around, after that first recurrence, for the cancer to come back is about 10 months on average. Then it's 6 months, 5 months, 4 months, and ultimately, once patients cannot tolerate more chemo or the chemo stops working, patients expire. So this what we call progression-free survival keeps getting shorter and shorter and shorter. The concept of maintenance therapy is how can we extend that time? Can we actually give patients more time off of chemotherapy before the cancer comes back? And in some patients, can we offer more cures? And this is where these new drugs, the bevacizumab, the PARP inhibitors, are very important. Not only does it seem in some patients that we can extend that time off of chemotherapy, but we're also able to offer more cures in these patients. And that's one of the main reasons I think is behind the decrease in mortality we've seen over the past decade. Okay. This is a result of 3 separate trials looking at 3 different PARP inhibitors in patients with recurrent ovarian cancer. All of these patients had cancer that recurred at least 6 months after the last course of platinum-based chemotherapy. All of these patients received an additional course of platinum-based or carboplatin-based, in most cases, chemotherapy with a response. And all of these patients were then randomized to either receive nothing at all, which was the standard of care a number of years ago, where patients, once they finished their course of chemotherapy, were just watched, versus going on a course of these oral PARP inhibitors. In SOLO2, it was Lynparza or olaparib. In NOVA, it was Zejula or niraparib. And in Ariel 3, it was Rubraca or rucaparib. And as you can see, all of these trials showed the same thing. The patients who took the PARP inhibitors after they finished the chemotherapy had a much longer, what we call progression-free survival than patients who did not. Within 6 months, patients who were on the placebo, who did not take the active drug, had a recurrence of cancer on average, versus at least 1.5 years for those patients who took the medication. Now, interestingly enough, and this is something that is really unheard of in recurrent ovarian cancer, patients who were placed on these PARP inhibitors also lived longer. So these are patients who are considered incurable. These patients who we know, unfortunately, the cancer will keep coming back in. But in SOLO2, which looked at using Lynparza or olaparib in patients who have a BRCA mutation, these patients ended up living on average about 1 year more, a little bit over 1 year more than patients who were on the placebo. This is despite the fact that many patients who were on the placebo arm of the trial went on to receive additional treatment with PARP inhibitors later. So this was really groundbreaking when this was presented 2 years ago. For the first time, we were able to show a drug that has been approved for the treatment of recurrent, or not the treatment, for the maintenance of patients with recurrent ovarian cancer, improving their overall survival by a very significant amount of time. This is a different clinical trial looking at the same drug, now looking at using these medications in the upfront setting. Because these medications were so successful in ovarian cancer, people started thinking, why can't we use it in patients in the upfront setting? So basically, patients who are just diagnosed with advanced stage ovarian cancer, who just completed chemotherapy, can we extend their lives? Can we offer more cures? And for one of the first time in recent memory, we have a trial, the SOLO1 trial, looking at patients with either mutations in the tumor or mutations in the patient's DNA with a BRCA gene, who went on to get surgery and then chemotherapy, or chemotherapy with platinum agent, followed by a maintenance treatment with olaparib for a couple of years. Patients were randomized once they finished the chemo to either 2 years of olaparib or Lynparza or the traditional placebo. And as you can see, this is at a follow-up of 7 years. And at a follow-up of 7 years, more than half of the patients with advanced stage ovarian cancer who were randomized to the Lynparza were alive without evidence of cancer, more than half of them. And this was true even when you followed these patients out to 7 years, which is unheard of. So many of these patients would be considered cured at that point, because we often say if you were without evidence of cancer at 5 years, you're considered cured. And this held up for these patients. Whereas if you notice, for those patients who were in the placebo arm, these patients more than half of them recurred or died at that point. And unfortunately, more than half of them were dead at the 7-year mark, despite in many cases receiving PARP inhibitors in the future. So this is a big breakthrough in my mind for these drugs, and one of the reasons I think these drugs are helping cure more patients. Now, if you remember, there were this is as I mentioned before, these drugs were first looked at to see if we enhance progression-free survival. This is the same trial, the SOLO-1 trial, which basically showed that patients who were on the Lynparza for 2 years afterwards, on average, did not suffer for a recurrence for a period that was 3 times, 4 times what we'd expect normally. Most of the time, within a year, like I said, we'd expect the cancer to recur. In the patients who took the olaparib, the average time until the patients recurred was almost 5 years, which is almost, again, unheard of in this setting. Now, as I mentioned before, there were 2 other drugs who were tried in the recurrent setting that are in the same class as olaparib, niraparib and rucaparib. And interestingly enough, these drugs were also used in the upfront setting for maintenance therapy. This is a trial called the PRIMA trial looking at niraparib, which is commonly known as the Zejula, in patients with advanced stage ovarian cancer. And again, just like in Lynparza, the outcomes of patients who took the drug were much better than those patients who were on the placebo arm in this trial. The progression-free survival was, again, significantly better. And as you notice, it was at least, on average, twice as long as what we'd expect in the placebo arm. The one difference between this trial and the prior trial is that this allowed higher risk patients to be enrolled, and it also enrolled patients who did not have a BRCA mutation. And even in those patients, if you looked at the overall patient population, Zejula helped extend the progression-free survival. This is a third trial looking at Rubraca in the same setting, again, advanced stage ovarian cancer, both in the homologous recombination deficient and in the overall patient population that included patients who did not have these BRCA mutations. The outcomes for patients in terms of progression-free survival were significantly improved. We don't have outcomes in terms of overall survival for these patients, but the curves are already, interestingly enough, very similar to what you see to what we saw in olaparib, where I think there is probably going to be some sort of survival advantage for these patients in the future. This is, again, another example of how well patients do even when they have very advanced stage ovarian cancer. This is the results of a PALA-1 trial, which combined olaparib with bevacizumab in patients with really high-risk cancer. And if you look at the BRCA mutated patients, most of these patients were alive and well at 5 years, as opposed to about half of the patients in the placebo arm, in the arm that just received bevacizumab, being alive at the 5-year mark. So again, this was groundbreaking when it was presented, because again, we are showing that we are able to keep patients alive and extending their lives using these drugs in the maintenance setting. Moving on to a different, more cutting-edge approach to treat ovarian cancer, which is immunotherapy. This has been all the rage for the past, I would say, half a decade at least. And we now know the importance of the immune system in terms of keeping cancers at bay, but also fighting cancers. And we now know that it's a complex interplay between the immune system and cancer cells. And it's a whole cycle that starts from the immune system recognizing cancer cells, to then directing the immune cells to the cancer, and then killing off the cancer directly. And what I'm going to present next are some of the different approaches we've used to use the immune system to fight off cancer. So the largest amount of research that's been done is around what we call checkpoint inhibitors. This has been where you've heard some of the Nobel Prize winner research has been in. The ability to block the cancer cells. So these drugs basically help the unmask the cancer cells and reduce their ability to evade the immune system, both in the way they present themselves to the immune system, which is a class of drug called the CTLA4 inhibitors, and the PD-1, PD-L1 inhibitors. There is another approach to immunotherapy that uses the patient's own immune system or immune cells to fight off the cancer. This is the concept of these tissue infiltrating lymphocytes or chimeric antigen receptor treatments or CAR T therapies that you've heard of, that you may have heard of. And finally, there's the concept of using vaccines or cancer vaccines, which the role of those is to basically present the cancer proteins or antigens as foreign to the body so that the body could then mount an immune response against the cancer. We're going to start off by talking about the checkpoint inhibitors because these are the most common form of immunotherapy that's being used. It's been very successful in lung cancer, melanoma, a number of different cancers. And as you can see, there's a number of these drugs that have been approved so far in the treatment of cancer. They are all what we call monoclonal antibody. That's why they end up with a name that ends with MAB. And the list is continuously being updated. The first drug that was approved is ipilimumab, which is a CTLA4 inhibitor, followed by nivolumab and pembrolizumab, which are also very commonly given. There are more recent developments with avelumab, cemiplimab, atezolizumab, which have been more recently approved. Here's an example of a patient with ovarian cancer who received nivolumab with a significant response in her cancer, despite the fact that the cancer was itself resistant to the most commonly given chemotherapy. Unfortunately, the response rates of more typical patients with ovarian cancer to immunotherapy has been much more limited. And it looks like it's only a minority of patients that will actually benefit from immunotherapy when it's used on its own. And when we try to use it in combination with other treatments like chemotherapy or bevacizumab, there unfortunately was not a great response to the addition of these immune checkpoint inhibitors. As opposed to the PARP inhibitors or bevacizumab, the addition of these drugs did not end up improving outcomes for patients with ovarian cancer, even when used upfront. This is another clinical trial looking at combining an immune checkpoint inhibitor with bevacizumab, which is the drug that we had mentioned before that's used to block the blood supply to ovarian cancer. And the response rates, unfortunately, were pretty limited. Even though it was successful in some patients, a lot of patients did not end up responding to the treatment. We also tried combining different immune checkpoint inhibitors. Ipilimumab, which is a CTLA4 inhibitor, was combined with nivolumab, which is a PD-1 inhibitor. And this approach has been successful in a number of cancers, including melanoma. So we tried this approach in ovarian cancer, and this is a clinical trial looking at the combination of ipilimumab plus nivolumab versus nivolumab alone. And it seems like the outcomes were better for some patients. The progression-free survival was not great. It went from 2 months to 4 months. But there was a subset of patients, particularly patients who had fewer treatments, particularly patients with clear cell cancer, where this approach could be successful and is very promising. This is another very interesting trial that was published last year in JAMA Oncology. In this trial, the investigators used pembrolizumab, which is another immune checkpoint inhibitor, plus bevacizumab, which is that blood growth factor inhibitor, in addition to what we call metronomic oral cyclophosphamide. Cyclophosphamide is a very old chemotherapy drug. In this setting, it is used at a small, low dose to prime the immune system. Patients were given infusions of pembrolizumab and bevacizumab every 3 weeks, and took the oral cyclophosphamide or Cytoxan every day, basically. And this continued for up to a year. Interesting enough, this is what we call a waterfall plot. Anything that's above that line that you see in front of you, above the 0, means that the tumors have grown. And anything that's below that line means that the tumors have shrunk. And anything that's below the blue line means that the tumors have shrunk to a significant extent. And as you can see, this waterfall plot is actually very promising. And it showed that almost half of the patients responded significantly to the drug combination. This was even more surprising because we found that in patients who had prior treatment, who had shown that their cancer was resistant to chemotherapy, there were patients who had 3 complete responses. So when they went on the treatment regimen, the cancer completely disappeared. This, again, is a very promising approach to using immunotherapy in combination with other drugs. One of the, it's sort of a chemotherapy-free regimen that seems to hold a lot of promise. Another interesting pathway that we've been recently involved with is what we call the gas-AXL pathway. The AXL protein is present on the surface membrane of a lot of cancer cells. Activating that pathway leads to cancer survival and proliferation. It also allows the cell to migrate, mutate, and then spread more easily, as well as to evade the immune system. It seems like this pathway allows the cancer cell to express more proteins that could then downregulate or dampen the immune response to the cancer itself and lead to a better survival of these cancer cells. Unfortunately, initial attempts at targeting this pathway did not work well. What we found out was actually by using a decoy protein, basically a protein that coats what we call the Gas6 ligand, or the protein that attaches to the AXL protein on the surface cell, you can inhibit that pathway more successfully. And we're currently involved in a very promising trial looking at the addition of this drug, AVB500, which is called Bitarixept, in addition to chemotherapy, to see if this helps improve the outcomes for patients with recurrent ovarian cancer where prior treatments with chemotherapy failed. Again, a very promising drug in a trial called the ARAVIVE trial. Another promising avenue that Stanford's been involved in is using what we call natural killer cells. Natural killer cells are one of the ways your body can kill off a lot of cancer cells. And one way to use these in the fight against cancer is to actually collect the natural killer cells from the patient's own immune system. So basically, you extract these natural killer cells from the patient's blood. You then activate them with what we call cytokines. These are called cytokine activated or CI activated natural killer cells, or CIKs. Then you train them to fight off the cancer, and at the last, or identify the cancer cells. And right before you reinfuse these cells back into the patient to fight off the cancer, you introduce into these cells this inactivated vaccinia virus, which when it enters into the cancer cell will release a payload that then kills off the cancer cell more efficiently. So this combination of the activated natural killer cell and the vaccinia virus then gets reinfused into the patient, hopefully killing off the cancer. This is another clinical trial that we're involved with at Stanford, and we're currently accruing patients to it. Finally, the last promising approach, or the last approach that we're using to fight off the cancer, uses actually vaccines to help fight ovarian cancer. And in this setting, there is a protein on the surface of many ovarian cancer cells called the survivin protein, and it allows cancer cells to survive more easily. The vaccine is designed to prompt the immune system to fight off the cancer, and we've enrolled patients in a trial looking at this vaccine to, in addition to that oral metronomic Cytoxan and another immune checkpoint inhibitor, to help see if we can fight the cancer more efficiently. These are the results of our first promising trial using this approach, and we're now looking at furthering research into this approach for patients with ovarian cancer. So this is the slide just to resume what we talked about today. Again, I want to emphasize the good news about treating ovarian cancer, which is the death rate and the number of patients with ovarian cancer has been falling pretty steadily over the past decade. Thank you very much. And I guess now, I don't know if we have time for some for Q&A. I think we have
just
enough time for that.
Yes, thank you so much, Dr. Karam. It was really exciting to hear so much promising research going on in the world of ovarian cancer. Thanks for...
Yeah, and I think the picture's been very, I mean, for the first time in many, many years, we've seen sort of declines in the numbers and death rates from ovarian cancer, which is some very good news, I think.
Very promising news. I think those PARP inhibitors have really changed the ballgame, and I'm sure you're seeing that.
Yeah.
We do have some questions that came in. If people have additional ones, please enter them into the question box on your screen. We'll start kind of from pre-diagnosis. Someone has a question about why low-cost pelvic ultrasounds are not used to screen women for ovarian cancer on a wide scale, say during yearly gynecologic exams.
Yeah, that's been our holy grail for decades, unfortunately. And, you know, initially, if you look at the research looking at ovarian cancer screening, particularly with ultrasounds, since they're low risk and pretty low cost, this goes back to the 1990s, unfortunately. Both there was a trial in the US looking at screening for colon cancer, prostate cancer, ovarian cancer, amongst other cancers, as well as several trials in the UK that looked at this using both a ultrasounds on its own, blood work, as well as a combination of ultrasound and blood work. And unfortunately, none of them showed that the detection rate or overall survival was different for those patients who were enrolled and underwent regular screening with ultrasound or blood work. So unfortunately, for the average risk women, the data is not out there to support using ultrasounds to be able to detect ovarian cancer in an early stage.
And are you aware of any newer technologies that might be useful in achieving better detection?
People are starting to look at actually molecular markers, either blood work, blood tests. People have probably heard of cell-free DNA. Nowadays, you can detect DNA from differences inside the blood without looking at cells directly. And some people are starting to look into whether or not detecting DNA from cancer can allow you to detect ovarian cancer early. People have also looked at using a concept similar to Pap smear, where you use this similar approach, looking for the DNA of cancer cells, ovarian cancer cells, in Pap smears collected at the time of an annual exam. So those are two approaches that people are using, blood work and direct testing, to look for the DNA or molecular signature of ovarian cancer to see if we can detect it early.
Great, thank you. Kind of related to that, an audience member asks, how hopeful should we be about the possibility of liquid biopsy technologies for surveillance of recurrence?
Yeah, I mean, I think the concept of liquid biopsies and what we call cell-free DNA analysis is basically the same. What you're looking at, or what you're looking for, is the evidence of this DNA from the cancer inside the blood. It does have its limitations. Unfortunately, some cancers do not release the DNA into the bloodstream in a fashion that allows you to detect them very easily. Also, there are some inherited mutations, like a BRCA mutation, that you can find in the blood anyway. So there are some limitations there, but people are looking at using this approach to see if we can detect recurrences more or earlier in patients who have established diagnosis with ovarian cancer. My goal, though, is to try and see if we can detect it early or treat it aggressively first and prevent the recurrence altogether. That should be everybody's goal.
Yeah, sure. And I think the PARP inhibitors, again, are helping with that. With
Yeah.
regard to the PARP inhibitors, for someone who maybe was treated with surgery and chemotherapy and did not receive maintenance PARP inhibitor and are now doing well 5 years out with no evidence of disease, is there any value to treating them with a PARP at this point?
No, because I mean, essentially, they are considered cured. They're well, I mean, as I showed in the prior slides, most recurrences happen by year 1 and year 2. It's unusual for recurrences to happen after year 5, but they do happen. Unfortunately, there's no indication that taking PARP inhibitors beyond that initial treatment is helpful.
Okay.
And these drugs come at a cost. They do increase the risk of certain liquid cancers. So patients who are on these drugs have a higher risk of developing liquid cancers like acute myeloid leukemia or what we call myelodysplasia.
Okay.
So it's not without its risks.
Right. Very good to know. And someone was asking about your opinion of combining the PARP inhibitor with Avastin due to the risk of bowel perforation and things like that. But it sounds like that's been done in several clinical trials. Can you comment on the safety of that?
Yeah, yeah, it's been examined in a number of different trials, initially in the recurrent setting. But as I showed you up front, there's a trial called the PAOLA-1 trial, which enrolled patients with advanced stage ovarian cancer who took bevacizumab with chemotherapy up front. This is very commonly done in Europe, and then received the Avastin and Lynparza or olaparib together afterwards. There was definitely a higher risk for perforation with the bevacizumab. The risk is no different than it was in other trials, and there was no real difference between the two groups. The blood pressure issues may be more common when you use the combination. There's certainly more side effects when you use the combination, but perforations were not more common.
Okay, got it. Can you tell us a little more about the natural killer cell trial going on at Stanford? Is it currently open for enrollment? And are patients with recurrent ovarian cancer encouraged to participate?
Yeah, so this is a very interesting trial. Like I said, it's a trial that uses your own immune cells. It's a phase 1 trial, so it's a very, very early trial. There's not much data on it. We don't really know about the safety, and a lot of what we're trying to do with this trial is figure out how safe and feasible this is. We are enrolling patients, but because it's a phase 1 trial, the number of slots is very limited. The treatment is somewhat involved because it involves collecting your cells, sending them out to a special lab, which is going to activate the natural killer cells and add those vaccinia viruses, and then getting an infusion back after a course of treatment of chemotherapy to reduce the immunity in your body, so that you can allow these cells to take over. The trial is ongoing. We are enrolling patients. there is quite a bit of wait period because the slots are very limited, and we can only enroll 1 or 2 patients at a time.
Okay. And I assume if someone's interested in participating in the trial, they should contact the trial
Yes,
coordinators at Stanford, available on the website.
absolutely, and we're happy to help them out. And, you know, that there's not really a lot of requirements for patients. I mean, patients have to have certain requirements to participate in the trial, but they're not very strict. It doesn't really have limits on how much treatment you've had, and whether your cancer is sensitive or not to prior treatments. It's pretty open to various patients with ovarian cancer.
Okay. Good information to know. Are there any other promising open enrollment immunotherapy trials that you could highlight for recurrent ovarian cancer?
We'll hopefully in the near future be reopening the vaccine trial that I mentioned to you before, using the Survivin vaccine approach. I don't have any idea exactly of the timeline, but hopefully that will be happening soon. We also have a trial open with using this AVB500 or Bitarexcept in combination with chemotherapy that also seems to be promising. It's a concept that was homegrown to Stanford, and there's a company now called Aravive, which is sponsoring the trial. We also are very excited about this combination. It's not immunotherapy, but it does work on the immune system because the Gas6 AXL pathway allows the cancer cells to hide from the immune system more efficiently.
Okay. Someone would like to know if it's standard for biomarkers to be tested at the time of surgery, or does that happen later in treatment? So maybe, I'm not sure exactly which biomarkers they're referring to, but maybe you can talk about what you traditionally test for at the time of surgery and what you maybe do later on, if anything.
Yeah, I think what they are probably referring to is what we call sequencing the tumor itself, what we call next generation sequencing. It is our typical course of action in any patient with advanced stage ovarian cancer to not only check for inherited mutations in the BRCA genes or other genes, but also to test the tumor for a variety of DNA mutations, because it allows us to better tailor the treatment for many of these patients. So we often will either get a tissue biopsy or a liquid biopsy if tissue is not available, to see if we can identify these mutations in the cancer. As I'd mentioned before, there's a number of patients with ovarian cancer who don't have a mutation in the DNA, but have one, or a BRCA mutation in particular, in the tumor itself without having one in their own DNA. And it's important to detect those patients because those patients really benefit from the PARP inhibitors. There are also other patients where immunotherapy could potentially be very helpful. Like I said, there's a small percentage of patients who respond really well to immunotherapy, and in particular, those patients who have tumors with high tumor mutational burden or microsatellite instability. These patients are rare, but they are particularly good candidates for immunotherapy should the cancer come back.
Yeah. Okay. You showed a lot of data with the approval of 3 different PARP inhibitors. So how do you choose which one to use in any given patient, or do you just have a favorite go-to?
Well, so all 3 drugs, the olaparib, rucaparib, and niraparib, are approved in the recurrent setting. Although if you look at the drug companies are slowly pulling out some of the indications in the recurrent setting. There are only 2 drugs that are currently approved in the upfront setting, Zejula or niraparib, and olaparib or Lynparza in the upfront setting. Lynparza is probably the longest sort of we've had the longest experience with, As I showed in the prior trial, we have the SOLO-1 trial with up to 7 years of follow-up, the SOLO-2 trial, but this is mainly in patients with BRCA mutations. Olaparib is not approved for patients who don't have a homologous recombination deficiency. For those patients who don't have a homologous recombination deficiency and want to be on a maintenance PARP inhibitor in the upfront setting, Zejula is the only one that's approved right now.
I see. Okay, so it's really determined by the cancer itself.
Yeah.
We have time for one last question. You mentioned that HIPEC is successful in patients who have had neoadjuvant chemotherapy. Is it also being used in patients who are just having chemo after surgery?
So the trials are ongoing for using HIPEC after upfront debulking surgery.
Okay.
But there's no, unfortunately, high-level data to show that it's actually helpful. So our typical patient who we think will benefit from HIPEC has to be in a specific category. Typically, these are patients with stage 3 cancer that are undergoing neoadjuvant chemotherapy. The trial did not allow patients with stage 4 cancer to be enrolled. And these patients have to be sort of relatively fit to be able to qualify for HIPEC. We don't currently use HIPEC in patients with recurrent disease because, unfortunately, there's not much data. In fact, the preliminary data showed that it's possibly not helpful in these patients with recurrent cancer, and we don't use it with patients undergoing surgery upfront because we don't know how much benefit they get from it at that point.
Okay. It sounds like we have to wait for some more data to come out then. Well, with that, I thank you so much for being with us this afternoon. We all learned a lot, and I wish you a wonderful rest of the day. For those of us that are staying for the rest of the conference, we're going to have a short break, and we'll come back at 2:45 for Living Well with Cancer with Dr. Kate DeVarney. See you there.
Thank you so much.
Thank you.
Bye.
Bye-bye.